thank you all for joining our special kickoff of the year, Diabetes State of the Union. I'm Dr. Sarah Hallberg, Medical Director here at Virta, and I'll be moderating the session today. We're gathered here for a very specific reason. Diabetes is undergoing a swift and dramatic change. There are new discoveries and advancements in research and technology that have changed fundamentally how we understand and treat type 2 diabetes. We wanted to gather leading medical experts in industry to break down these trends for you. We have an esteemed panel of speakers joining today, covering a 360-degree view of what you need to know about diabetes as we kick off 2021. Joining us today is Sami Inkinen. He will give us the top 5 predictions for diabetes this year. Then Dr. Alan Moses will share the updated pharmacologic approaches to treating type 2 diabetes. Dr. Robert Ratner will follow up with the flip side, updated non-pharmacologic approaches to treating type 2 diabetes. And Dr. Shantanu Nundy will close out with his perspective on virtual care models in the time of COVID. We will have 15 minutes at the very end for a live Q&A with all of our panelists. With that, I'll hand it over to our first speaker, Sami Inkinen, the CEO and co-founder of Virta Health. Welcome, Sami.
Well, Dr. Hallberg and Sarah, thank you so much for the kind introduction, and I'm excited to be here. Again, this is Sami Inkinen, CEO and co-founder of Virta Health, and I do have to say that the real experts today are Dr. Moses, Dr. Ratner, Dr. Nundy, and Dr. Hallberg. So I'm just going to give a warm-up here. Again, as Dr. Hallberg mentioned, I'm going to share 5 predictions for diabetes care, particularly driven by innovation in technology. But before going into those predictions, I will share just a little bit about the context of diabetes. As I think many of you listeners, and by the way, we had more than 1,000 individuals sign up, so thank you everyone for tuning in. A little bit about the diabetes as an epidemic. About 30 million people in America have type 2 diabetes today, or are living with type 2 diabetes today, which is a massive number. And sadly, those of you who are economically inclined, if you look at the total cost of diabetes today in America alone, it's more than $400 billion, which happens to be more than the combined market that 2 leading online or tech companies are going after. So this is Google and Facebook. So it is mind-blowing to think about that one disease in one country is costing us more than the massive market that those tech giants are going after. So sadly, this is a huge problem we are facing. What's even more alarming is if we extrapolate, and this is not just an extrapolation, but prediction by CDC, the prediction is that diabetes rate and the number of people will about double over the next decade. I truly hope that that's not going to happen, both from a human, negative human impact perspective, as well as the economic impact. So if you just double the $400 billion a year cost, you're looking at almost $1 trillion for one disease. I don't even want to guess how we would be able to pay for that, not to even mention the negative human impact. So that's what we are facing. Now, my role here was to talk about predictions, and hopefully optimistic predictions. And obviously, I wouldn't have my job and role as a CEO of Virta Health if I thought this is all doom and gloom and there's no way out of here. But a good question to ask is, a lot of money and ideas and innovation has gone into digital health over the last couple of years. why haven't we seen much of a change in the diabetes trends yet? My own opinion is that one reason is if you just take technology and do what you've done in the past, nothing's going to change. And I think it's the Einstein quote that it's the definition of insanity to do the same thing over and over again and assume different results. Okay, so that's the doom and gloom. I'm going to share 5 predictions to hopefully turn this epidemic around, the diabetes epidemic, at least a little bit. So here's my 5 predictions based on my own experience now scaling and running Virta Health for the last 5+ years. 1, telemedicine will improve equity and access. And maybe this is an obvious point, but thanks to telemedicine and ability to deliver everything or care virtually, you don't have to live in New York or San Francisco or Atlanta anymore to get access to the very, very best care. Access to the very best care, at least virtually, is now available as easily as access to your nearest smartphone or computer. And I'll just give an example from my own experience running Virta. We work with a couple of Native American tribes. We work with blue-collar employers, white-collar employers, and generally employers nationwide. And we treat patients not just in all 50 states, but patients living in cities and rural areas and so forth. So I am a huge believer that telemedicine is not just about convenience, but it actually improves equity and access. Second optimistic prediction is that whole patient care, not just what we call symptom by symptom whack-a-mole, will become a new priority. And what I mean by this is, in the first wave of digital health companies and solutions, there were a lot of apps addressing a narrow slice of a chronic disease. For example, there were apps addressing, oh, you have a high blood pressure, here's an app for that. Oh, you have high blood sugar, here's an app for that. Oh, you have heart disease, here's an app for that. Now, ultimately, we are treating humans, and a lot of these chronic comorbidities go hand in hand. So my prediction is that provider-led virtual care companies will really focus on the whole patient for a number of reasons, and that will drive much better outcomes, much better patient experience. So that's the second prediction, positive prediction. Third positive prediction is that fee-for-service will be, not entirely, but largely replaced with value-based care models. And I think many economists say that you get what you pay for. And if you pay for more transactions, you get more transactions. I'm a huge believer that the kinds of models that particularly Medicare Advantage is using, where you actually get paid for results, or your profits are defined by savings and improved outcomes, will force a lot of companies in the chronic disease and diabetes world to actually focus on outcomes. And needless to say, if you only get paid for results, you will go out of business unless you improve outcomes. And obviously, this has been a promise for the last decade, but I do think that value-based care models will accelerate as we move forward. And partially, I would say, thanks to COVID-19 as well, as the providers who were just paid for transactions, when people didn't go and visit providers, obviously revenues dried up. Prediction 4, positive prediction. Provider-led and tech-enabled continuous remote care will become the new normal. And what I mean by this is that the first wave of telemedicine was more or less replicating the episodic doctor's visit with a phone call or connection through a smartphone or computer. We all know that if you're living with type 2 diabetes or chronic disease, it happens 24/7, 365 days a year. And to truly provide the necessary support and achieve the outcomes, an episodic virtual care visit, maybe once a month or once a quarter, isn't truly going to change the outcomes. So I believe that thanks to technology, we will be able to deliver necessary and useful care on a more or less continuous basis by monitoring patients and then responding to any needs that the patients might have, whether that happens multiple times a day or multiple times a week. And then the last and the fifth positive prediction is that thanks to many of the 4 things that I mentioned first, we can actually not just improve clinical outcomes for people living with chronic diseases, but fundamentally reverse many of these chronic diseases by addressing the root cause of these conditions. So I believe that in multiple conditions, we can move away from, upgrade our care goals from addressing a symptom, such as high blood sugar, by actually addressing the root cause and fundamentally reversing or putting the chronic disease into remission. So those are my 5, I would say, optimistic predictions how particularly technology will change not just care delivery and patient experience, but outcomes to address this rapidly growing and ballooning diabetes epidemic. And I will briefly share a few things about Virta Health and how we are leveraging all those 5 ideas that I mentioned, and which obviously gives me the confidence to say that I do think the 5 positive examples might be the future of diabetes care and outcomes in the future. So point 1, we as a company, we started with this bold promise and objective, that is reverse type 2 diabetes with a combination of intensive continuous telemedicine-based support and individualized nutrition treatment. And as you might hear later in this presentation, we have achieved that both in commercial patients and in our clinical trials. So we were able to take people living with type 2 diabetes, perhaps already on insulin, and deliver perfect glycemic control while eliminating the diabetes medications. So that's where we started, and we've achieved that. What's equally exciting is that when we've addressed and improved and reversed type 2 diabetes and obesity with substantial weight loss, it turns out this addresses the whole health of the patient. So when you eliminate or substantially improve diabetes and obesity, it turns out multiple other chronic comorbidities improve, such as inflammation, cardiovascular disease risk markers, and liver markers. So I mentioned earlier that the focus will be on whole health, but you can only actually move the needle on whole health if you address the underlying drivers of it, which with many chronic diseases are diabetes and obesity. So we've achieved that. And then the last thing I wanted to mention about our work at Virta Health is that as we now work with more than 100 large organizations ranging from employers like Home Depot or Comcast to even the Veterans Administration, we started getting questions towards the end of last year, 2020, saying, wow, wonderful, you reverse type 2 diabetes, but you have all this infrastructure to help people. Could you also help my members or employees who may be earlier in the disease spectrum, perhaps individuals with prediabetes, or people living with type 2 diabetes who would just want to get support and may not yet be ready for type 2 diabetes reversal? And we said, yes, absolutely. We want to help patients and people living anywhere in this spectrum, from obesity to prediabetes to type 2 diabetes. So we expanded our offering and support to cover individuals anywhere in this metabolic health spectrum. So I'll just finish off with hopefully and on an optimistic note, and that is to say that let's not just extrapolate from a massive epidemic to even bigger epidemic. I think we can learn, improve, and hopefully partially with the help of technology, reverse the type 2 diabetes trend. I think it's a moral imperative that we actually turn the corner. Otherwise, this massive human and economic tragedy is just going to steamroll over all of us. So with that, I'll hand it back to Dr. Hallberg.
Thank you, Sami. Optimism is what we all need, I think, as we come upon this new year. Up next, let's give a warm welcome to Dr. Alan Moses. Previously, he served as the Senior Vice President and Chief Medical Officer of the Joslin Diabetes Center. He was also the Global Chief Medical Officer of Novo Nordisk. Currently, he's taken his multiple decade-long experience in biotechnology and pharmaceuticals, and he's running his own consulting practice at Nemor Consulting. Welcome, Dr. Moses. I'll turn it over to you.
Thank you very much, Dr. Hallberg, and thanks to the Virta team for allowing me to participate in this wonderful webinar. I think Sami did a great job setting the stage for how the nature of diabetes care and indeed pre-diabetes care can change over time. I've been given a more traditional topic in terms of the pharmacologic approach to type 2 diabetes, but I want to try to convince you by the end of this few minutes that it's no longer quite the same tradition as it was just a few years ago. And the goal here is to rethink the pharmacologic approach while keeping the whole patient top of mind. So first, let's look at the macro level. In what is the status of type 2 diabetes in 2021? And Sami's already given you some flavor for this. I think it's really important to recognize that the type 2 diabetes pandemic is there. It's unfortunately very much alive. The incidence and prevalence continue to increase, fueled by lifestyle, the combination of genes and environment. We know that that type 2 diabetes itself is really the endpoint of progressive metabolic dysfunction. Again, as Sami has already alluded to, with the concept of starting earlier in this metabolic pathway, if you will, beginning with overweight, going to obesity, increasing insulin resistance, and ultimately beta cell failure that produces the hyperglycemia that is responsible for many of the microvascular complications associated with diabetes. And as we've unfortunately learned during the COVID pandemic, an increased morbidity and mortality in individuals with both type 1 and type 2 diabetes. I think one of the challenges, and again, really gets to the heart of what Virta is trying to do, is that we have the ability today with pharmacologic agents and with non-pharmacologic agents to achieve metabolic control. But we're actually not achieving that on a population level the way we need to reduce the individual costs. I don't mean monetary costs, but the healthcare costs on the individual and the cost to society. But there are opportunities to treat type 2 diabetes more holistically, and that relates both to glycemic control and beyond glycemic control. We also have to recognize that technology, not only the technology that we're talking about with the continuous care virtual model, but other technologies such as continuous glucose monitoring can really help safely reduce blood glucose levels, no matter the approach that's being taken. So what then is the evolution of type 2 diabetes pharmacotherapy? Glucose control clearly remains important, but I want to stress that it's insufficient by itself. Why do we want to try to achieve glucose control? Well, we want to reduce the symptoms and the consequences of hyperglycemia. There are evolving parameters to measure glycemic control so that glycemic control is no longer just your fasting blood glucose or random blood glucose or your hemoglobin A, A1C, but also new terminology such as time and range, which gives individuals a sense of what their glucose control is over a full 24 hours and actually correlates very well with oxidative stress from the lack of oxidative stress from not having your postprandial glucose levels rise. The goal, of course, is to reduce the microvascular complications associated with long-standing hyperglycemia, but as I've said, also to reduce the morbidity and mortality associated with the COVID infections. There is an increased focus, however, and I think this is critically important, on non-glycemic endpoints. We want to decrease the risk and consequences of hypoglycemia when those are induced by pharmacologic therapies. And I don't have time to go into detail about the different classes of medications. There are over 13 classes of diabetes medications currently available to treat individuals with type 2 diabetes. These are well outlined in the standards of care that are published by the American Diabetes Association, and I encourage you to refer to those. Current therapies, however, should really focus not only on decreasing the risk of hypoglycemia, but also preventing weight gain and inducing weight loss. We should think seriously about retarding the progression of diabetic kidney disease when it's present. We clearly should be thinking about how to improve cardiovascular outcomes, both congestive heart failure and atherosclerotic cardiovascular disease, because these are the major factors that increase both morbidity and mortality, particularly mortality of individuals with type 2 diabetes. And as Sami's already alluded to with some data from his one of his tables, we'd like to reduce the incidence and impact of non-alcoholic steatohepatitis, which is becoming an increasing problem in individuals with type 2 diabetes. Sorry there. So the ground rules really changed a little more than a decade ago, when in 2008, the FDA issued a guidance related to cardiovascular outcomes in type 2 diabetes, and the concern that some new diabetes medications might increase cardiovascular risk. This dramatically changed the development landscape for medications for type 2 diabetes. The guidance stated that all new medications for type 2 needed to be shown to be safe from a cardiovascular standpoint. And this introduced a new era of drug therapy that has continued to emerge now multi-billions of dollars later in terms of the clinical development programs. Well over 100,000 individuals with type 2 diabetes have been assessed for cardiovascular outcomes in dedicated cardiovascular outcome trials, or CVOTs. This has particularly applied to 3 drug classes, each of which has multiple agents. And again, I don't have an opportunity to go into great detail about this, but let me just highlight the 3 classes. The first were DPP-4 inhibitors. And this was at the crux of the story, not the reason for the FDA guidance, but the timing was such that these agents were also subjected to assessing cardiovascular safety. And they have all proven to be neutral from a cardiovascular safety perspective. That is, they do not produce any harm. They don't seem to produce any specific benefit either. They're well tolerated. I would say that they only have moderate glycemic efficacy compared to the 2 classes right below them. The GLP-1 receptor agonists, with which I was intimately involved in the regulatory process, ultimately have been proven not only to not have adverse cardiovascular effects, that is, safety has been proven, but also that agents with the longer half-life, those administered with a half-life that lasts 24 hours or is given once weekly, actually reveal cardiovascular benefit, and also have suggestive data, not yet definitive, for improving outcomes from renal disease in patients who have renal insufficiency. The third class of medications, the SGLT2 inhibitors, of which there are now 6 different members, have no adverse cardiovascular effects as well, and all members of this class have shown benefit on congestive heart failure hospitalization, particularly individuals with heart failure with a reduced ejection fraction. And some have revealed benefit for atherosclerotic cardiovascular disease as well. You'll see in a moment their impact on renal disease. So here's a table. This is derived from a meta-analysis conducted by Darren McGuire at UC Southwestern, looking at then 5 individual SGLT2 inhibitors that were approved and the cardiovascular outcome trials with which they were associated. The second column refers to the hazard ratio for overall MACE, or major adverse cardiovascular events, including MI, stroke, and cardiovascular death. And you can see that these hazard ratios, except for erdagliflozin, all are below 1, and that the confidence intervals for 3 of them strongly support a significant improvement in cardiovascular outcomes and MACE outcomes. That is driven to a large extent by the reduction in hospitalization for heart failure and cardiovascular mortality from heart failure in these individuals, where you can see that all 5 agents produce somewhere between a 27 and 39% reduction, all statistically significant, in the risk of overall hospitalization for heart failure. This is a game changer for type 2 diabetes. When you look at these agents in regard to their impact on renal disease, you can see an even greater benefit. Now, these data come from the cardiovascular trials for the most part, but all show a highly statistically significant difference, except for erdagliflozin again, which just is short of that, in terms of a reduction in deterioration of renal function. Now, there are caveats. One caveat is that there's an initial decline in GFR of a few millimeters per minute that stabilizes with these agents, and the standard of care goes down over time. The second is that these agents are not recommended in individuals who have a severe degree of renal insufficiency. And so you need to be aware of the label for the individual agents and the status of your particular patient when selecting these agents. The next category of the GLP-1 receptor agonists, clearly also from this meta-analysis, a different meta-analysis, and includes 7 different trials, strongly supports that those agents with a long half-life, those are all of the agents below the lixisenatide line on the table, reduce the risk of MACE, major adverse cardiovascular events. Some more than others, some just barely achieving or not quite achieving statistical significance, in part, one of these because of relatively small sample size, low number of events in the trial, but with a overall very positive result. What's interesting is that all-cause mortality is also reduced statistically significantly so for several of these agents. So for the first time, we have drugs for type 2 diabetes that not only treat hyperglycemia, and in some cases help with weight loss and avoid hypoglycemia, but also have a positive impact on the bottom line, that is, a patient's longevity. And I think this is something that we just hadn't seen before, and that's reflected by the fact that these agents now not only represent a focus on the whole patient, where individualized therapy needs to be chosen based on glycemic control, weight, the risk of hypoglycemia, the presence of micro or macrovascular complications, but also with reference to the underlying cardiovascular and renal status of the individuals. Both diabetes and cardiovascular standards of care recommend the use of SGLT2 inhibitors and or GLP-1 receptor agonists for individuals with known cardiovascular disease. And by the way, the 2 agents can be used together. These agents are also recommended as first-line therapy when there is the presence of CVD or renal disease in individuals who don't have diabetes. Not necessarily the topic of our discussion today, but that's the power of the SGLT2 inhibitors specifically. And importantly, and I think this fits well into the paradigm that Virta is establishing with non-pharmacologic care that Dr. Ratner will tell you about, that these agents can and should be used in the presence of diabetes in those individuals who have achieved glycemic control, target levels of glycemic control, if they have underlying CV or renal disease, because they appear to help in those situations as well. So thank you for your attention. I look forward to the questions at the end of the session.
Thank you, Dr. Moses, for showing us a great discussion on how research can really make important changes to our focus. Our third panelist today is Dr. Robert Ratner, who is currently the Chief Medical Officer of Virta Health. Dr. Ratner is also a professor of medicine at Georgetown University Medical School in Washington, D.C. After 35 years of active patient care and clinical research in diabetes, he also served for 5 years as the Chief Scientific and Medical Officer at the American Diabetes Association. Thank you, Dr. Ratner, for joining us here today. Over to you.
Thank you, Sarah. It's a pleasure to follow Alan in the discussion of keeping the whole patient top of mind. As Sarah said, I've spent my entire career doing clinical research in diabetes, and that's one of the reasons that I chose to come to Virta last year. Because of the emphasis on science, the emphasis on data, and the emphasis on publishing our findings to support the business case. Before Virta ever sold a contract, they initiated a clinical trial that Sarah Hallberg was the principal investigator for. This has all been published. It's available to you. We're happy to give you the PDF links for it. But what Sarah endeavored to do was to compare usual care with remote continuous care utilizing a well-formulated ketogenic diet. The study was designed over a 2-year period of time. And what you can see is the very rapid fall in hemoglobin A1C in the well-formulated ketogenic diet group with a commensurate fall in body weight. This resulted not from increased medical therapy, but rather from decreased pharmacologic therapy. Now, in the black line, you see the control group. And this is what we have traditionally seen in diabetes management. Over time, body weight goes up, hemoglobin A1C goes up, and so we begin to accelerate pharmacologic therapy. This is what we classically see. Virta reversed that process, and in fact, rapidly lowered A1C and weight, and as a result, de-prescribed medications. Now, those were mean values. Were we cherry picking? Were we simply looking at those that were most likely to respond? The answer is no. Here you see the baseline hemoglobin A1C levels in the 2 treatment groups. And you can see it's a broad category of glycemic control, with over half of the individuals under what the ADA would consider to be inadequate glycemic control. After 1 year, what you suddenly see within the Virta therapy group is that almost 60% now fall below the diagnostic threshold for diabetes. And those who miss their HEDIS guidelines of hemoglobin A1C less than 8, we've reversed that from 31% exceeding 8% down to less than 10%. So clearly what we're seeing is a population shift as compared to the control group in which you see very little change. Now, this is also seen in body weight. Again, we're looking at a population level assessment where you're seeing a significant proportion of individuals who are morbidly obese. Within 1 year, what you begin to see is a leftward shift in this body weight characterization within the Virta treatment group, with very little change in the usual group. Now, one of the major issues is how do you deal with sustainability? What I'm showing you are 1 year data and 2 year data. The study was designed to go for 2 years. we had an 83% retention rate within the clinical trial at 1 year. And at 2 years, a 74% retention rate. When you stop and think about obesity studies, weight loss studies, where the retention rate at 1 year typically is less than 50%, this is truly phenomenal. This is a lifestyle modification, not simply taking a pill or taking a shot. So we're looking at responses over a 2-year period of time with excellent retention throughout. Now, the question obviously is, well, that's fine for 2 years. Is it sustainable beyond that? We've collected and reported our 3.5-year data. Now, as I said, the study was designed as a 2-year study, which means that we could not ethically continue the usual care beyond 2 years, and we had to consent those who were in the Virta arm. But what you can see is literally a flat line from year 2 to year 3.5 in terms of the hemoglobin A1C reduction. We're maintaining that A1C reduction out to 3.5 years. Next question is, well, does it go any longer? We are currently completing data collection on 5-year lifestyle modification. We hope to be able to present that data later this year. So what we have are data showing that it works, it's sustainable, we reduce the need for medications. But now let's talk about the whole patient. What impact do we really see about outcomes? Virta is still a young company. We don't have long-term data beyond 5 years, and we don't have thousands, much less hundreds of thousands of patients for our cardiovascular outcome trial. However, a recent paper that came out last week suggests that the status of diabetes, prediabetes, or normal glucose has a major impact on cardiovascular outcomes. Now, this study is from China. It was published just last week in the Journal of the American Heart Association. But what you can see in the blue lines are the event rates for myocardial infarction, stroke, and all-cause mortality in individuals who progressed over a 10-year period of time from prediabetes to diabetes. In the green line, those who remained pre-diabetic, and in the red line, those who regressed to normal glucose. What Virta is doing is lowering glucose and bringing it under the threshold for the diagnosis of diabetes. Clearly, if our data can match this data, we're protecting the whole patient from MI, stroke, and all-cause mortality. Now, that's a hypothesis. Clearly, we're extrapolating from somebody else's data. But what about our own data? What impact do we have on atherosclerosis and MI? Well, you've seen this slide from Sami. This is from our 1-year clinical trial, where we not only are changing glucose, but we are significantly impacting inflammation. When we begin to look at inflammatory markers, 14 out of 16 fall with the Virta intervention as compared to the control group. We're seeing lowering of blood pressure. We're seeing alterations in lipids, and I'll go into those in greater detail. And so we are seeing a more generalized metabolic health within our patient population. Now, the issue of lipids has become very, very important, because keep in mind that what we're doing is we're instituting a low carbohydrate diet. You have to have calories coming from somewhere, and if you're taking them away from carbohydrate, you are necessarily increasing the percent of calories coming from fat and protein. We hold protein pretty constant, but what we're doing is we're instituting healthy fat diets, much like a Mediterranean diet. The argument has been that this is going to increase cholesterol and increase atherogenesis. These are our 2-year data from our controlled clinical trial, looking at the LDL phenotype within our patient population. At baseline, what you see is a predominance of the highly atherogenic pattern B. These are the small, dense LDL particles. Over a 2-year period of time, we're seeing a population shift away from that atherogenic pattern B towards a less atherogenic pattern A. These are the larger, fluffier, if you will, LDL molecules. So at least from a risk factor standpoint, there doesn't appear to be a problem with LDL. But that doesn't answer the question of atherosclerosis. What we did as part of this study was to measure carotid intimal medial wall thickness, a direct assessment of atherosclerosis. And what you can see with usual care over a 2-year period of time, there's a slow increase in the thickness of the intimal medial wall. If anything, there's no change in IMT in the Virta care or a slight decrease. Now, this did not reach statistical significance, so I'm not going to claim that we reduce atherosclerosis. What we can categorically say, however, is that the Virta well-formulated ketogenic diet does not increase the risk of atherosclerosis over a 2-year period of time. Now, we're not alone in coming to this conclusion. The consensus report from the American Diabetes Association on nutrition therapy came to the same conclusion, that carbohydrate-restricted eating patterns that did not restrict saturated fat don't appear to increase the overall cardiovascular risk. So we are confident that this will, in fact, have a beneficial effect moving forward. So I've mentioned the fact that we are very proud of being data-driven. These are the previous publications from our controlled clinical trial that are available to all of you. We've been incorporated into the ADA Standards of Medical Care. This shows 2019 when they first went in. We continue to be part of the standards of care in 2021. And we are particularly proud of our most recent publication from December of 2020, looking specifically at cardiovascular disease risk. So I think that we can continue to think of the patient in a holistic fashion. Dr. Moses has given you the pharmacologic approach. There is an alternative with a non-pharmacologic lifestyle approach. With that, I thank you very much, and I'll turn it back to Sarah.
Thank you so much, Dr. Ratner. I think the idea of focusing on a whole patient is something that just can't be said enough in its importance. Our last panelist today is Dr. Nundy, the Chief Medical Officer at Accolade. As CMO, Dr. Nundy directs Accolade's clinical strategy and solutions to improve health outcomes and the relationship between patients and their providers. Dr. Nundy is a practicing primary care physician in DC and an expert in global health policy. He has conducted research at Harvard Medical School, Johns Hopkins, and the Centers for Disease Control and Prevention. Welcome, Dr. Nundy. Thanks for joining us today.
Thank you so much, Dr. Hallberg, and such a pleasure. I'll just jump right in. On the theme of whole person, I think any State of the Union for any clinical condition, I think today would be remiss not to talk about COVID, right? I think, a question on a lot of people's minds is, why now? Why is now the time to really accelerate progress in diabetes care? And I think COVID creates both the problem as well as the opportunity for us to be seriously contemplating that. I think many of us here in different ways have really felt the acute pain of the traditional healthcare system that in so many ways has really, failed the response to COVID-19. And certainly folks with diabetes, those who are very well aware that that their diabetes puts them at higher risk of COVID and COVID complications are feeling it more than most Americans. And for me, as a primary care physician on the ground, it's actually, the silver lining has been to see the dramatic transformation that's happened in care delivery for folks with diabetes and others so quickly. So this is a view from my clinic. That's what telehealth looks like in a safety net clinic. It's just an old black phone that we put to our ears, and we were able to stand up drive-through testing. And I think for all of us today, that feels pretty routine, but even a year ago, I could say that I've never conducted a virtual visit as a doctor, and I never participated in a virtual visit as a patient. And I imagine a lot of us today are the same. And I certainly had never tested a patient outside of a clinic a year ago, and I certainly myself had never been tested outside of a clinic. And I've done both of those things in the past year. And so the question is, well, what does this mean, and what opportunities does that create for diabetes care? And it's not just virtual. Virtual's been getting a lot of attention, but at home as well, right? If you, there's been an acceleration in house calls as people have been more reluctant to be in a clinic environment. There's even ER level and hospital level care that people are getting at home. And so really the broader shift is not just the virtual, but the home and the community-based, all of which is aligned with the whole person orientation we've heard about, because your home is where most of your health behaviors live. So what we've seen, I think, a lot of policies will that have been enacted may shift, but I really think the cultural mindsets have shifted and will sustain. Right? Physicians now trust care outside of a clinic. Patients trust care outside of a clinic and online. Health systems have really come to appreciate how fee-for-service medicine impacts the resilience that they have. Policymakers have seen the potential of using mobile messaging, FaceTime, and other tools in a way that haven't, led to widespread problems with patient privacy. And certainly employers, I think, recognize more than ever the huge role that they play. And I know certainly in my one of my day lives as a CMO of Accolade, we've seen employers step up in a much bigger way than we've ever seen before. And so all those things, I think, build to a lot of the predictions that Sami had earlier, and I think have real implications for the health of patients with diabetes. So for us, what we see, sort of the acceleration that's move forward 10 years, is not necessarily a virtual or at home world. We see a world where care is going to be more distributed, where care is going to happen where health happens. We see digital enablement, something that is core, I think, to the Virta model we heard earlier, but this idea that using data and technology to really strengthen relationships, create more touch points, make care more continuous, but do so in a highly scalable way. And finally, decentralization, right? We see more decision-making moving to frontline health workers, but ultimately to patients who we recognize when it comes to diseases like diabetes are frankly in control of the medications they choose, to Dr. Moses' presentation, but also to how, to the sort of lifestyle changes that Dr. Ratner spoke about. So just wanted to sort of highlight three sort of ideas. A lot of people have likened virtual care to this idea of banking, right? We used to bank at a physical bank, then we could bank at an ATM, and now we can do things we couldn't have imagined before, like depositing a check on a mobile phone. And that's what's happening in healthcare, right? Care went from all being in a hospital or in a clinic to a drive-through testing site to now being delivered increasingly at home. But there's a caveat. I think the version 1 of telemedicine we have has a lot of limitations. The analogy that I use going back to banking is, imagine if you deposited $500 in your bank account, and then you had to send a fax to your bank to tell them that you deposited money. That was the experience of sort of version 1 telemedicine that a lot of people faced. The other is this idea that care is going to get more, as it gets more distributed, in some respects, it'll get more fragmented and complex, right? You may be getting care through your primary care doctor, you might be going to a hospital, you might be getting blood tests at home, you might be using services like Virta and others for mental health or for your chronic conditions. And so it becomes more important than ever to make sure that that data is being used to actually empower people and navigate them regardless where they are in the healthcare system. Because folks with diabetes, they also have kidney disease, they also have foot disease, they also have neuropathy. And so really whole person means that we have to integrate across these increasingly disparate care sites. And then this idea of digital enablement, which I think Sami and team did a great job talking about. But right now, most of telemedicine is taking an in-person interaction and making it digital. It's a lot like when my paper medical record became virtual. It just became a glorified, notepad. But really, what we need to do is use the tool, which is virtual, in order to and home-based, in order to actually change care. Right now that it's not so hard to see a doctor. Instead of seeing them every 3 months, maybe you have to connect with them every week or 2 weeks. And then ultimately, even changing the goals that we set for these solutions, where most of healthcare is very inertia driven, really being much more goal directed and saying, well, can we actually reverse people's diabetes? That is really the progression that we see a huge opportunity for. Just wanted to end with, I know a very hot topic right now in the countries around vaccines. Certainly around the country, different states, we're seeing folks with diabetes and chronic conditions being appropriately prioritized. But we think these three themes still apply here as well, right? What we're seeing, for example, with these centralized scheduling systems for getting the vaccine, they're just frankly not working. People are logging in multiple times an hour in order to get access. This is this idea of distributing more care to the periphery. Bringing the vaccines to the people instead of having to bring people to the vaccines and creating bottlenecks. So we really think these themes, I think, directly impact both the pandemic, the vaccination, public health campaign, and then, of course, diabetes care on an ongoing basis. Appreciate the opportunity to chat with all of you and look forward to the questions.
Thank you so much, Dr. Nundy. If I could have all the panelists come back, and we'll begin on our Q&A section. But really quick while they do, Dr. Nundy, it's, COVID has affected everything. And going back to that opening optimism, one of the things that certainly leaves us hope is that we can come out better in some ways regarding healthcare at the end of the day. Certainly something to be excited for the future about. We are getting some questions in now. This first one goes to Dr. Ratner and Dr. Moses, but please, anyone feel free to chime in. The question is, wondering if you can give some advice to the health plan benefit leaders in the audience. How should they think about their diabetes strategy given your updated approach to type 2 diabetes care?
Alan, you want to take the first crack?
Sure. So I think, having run a diabetes specialty clinic for a while, now so many years ago, there are still real challenges in diabetes care, as I alluded to, and Sami did as well. We have the tools, but we're not applying them effectively. So I think what health plans need to think about and what employers need to think about is the importance of keeping the population, their population, but also associated populations, healthy by early intervention. Waiting too long to try to, capture the cattle after they've gotten out of the corral and onto the range is not going to work. So beginning early, ideally in the overweight obesity phase, certainly in the pre-diabetes phase, with whatever intervention a patient will adhere to for the benefit of that patient, whether it be lifestyle modification, the Virta model, pharmacologic therapy. I'm less concerned about what rather than something. Do something and follow that patient on a continuous basis, which is one of the tremendous advantages of the Virta model.
So I would build on that, and I completely agree with the goal is to keep your employee population healthy. Right now, over $100 billion a year is lost in indirect costs to diabetes. That means absenteeism, lack of productivity. That's a huge cost to businesses. So I think that health directors need to keep that in mind as well. if you look at how healthcare has traditionally been delivered for people with diabetes, it's been a quarterly or semi-annual visit that takes 15 to 30 minutes. That's simply not adequate to get the level of control that's really necessary to minimize risk and complications and keep people healthy. I think that continuous remote care is the model moving forward for chronic disease, where patients are their own primary caregivers, but they have a contact whenever they need it to be able to provide the instruction and the guidance for optimal management.
Yeah, I just can't resist piling on because I get to spend a lot of time talking to employers and our customers, and I really, to build on both comments, which I completely agree with. I think the three keys are, number one, which I think you heard from both of them, is we have to expand the options available, right? We have the brick and mortar traditional 15-minute visit 2 times a year option. We need many more options across the diabetes spectrum, virtual, in person, places like the Joslin Clinic, pre-diabetes, diabetes, type 1 diabetes. We need to expand options. But in addition to that, we also need tools to engage the population. How many of us have implemented a program or bought a solution and not seen the engagement that we need? And the other is the ability to personalize that. If somebody wants to see an in-person provider, how do we give them search tools to get them to an in-person provider like the Joslin Diabetes Center that can provide that care, or to get them to a diabetes provider, frankly, that meets their racial or ethnic preferences and background, or if they want a home option to provide that, or if they want an option that's that doesn't require pharmacologic therapy. So for us, I think it's you need an engagement solution, a personalization tool, and then you need to dramatically expand options for folks across the spectrum. Thanks.
Thank you all. This next question is directed specifically at you, Dr. Nundy. You mentioned to overcome vaccine hesitancy, we need a better patient experience. What are some quick hints that benefit leaders can do to improve patient experience for their employees?
Yeah, one of the ideas that I've been talking to a lot of employers about is this idea of diffusion of innovation, right? That if you look at any adoption curve, like take the iPhone, right? There's the people who first day they're going to wait in line, they're going to camp out, and they're going to get the iPhone just because they read about it on CNET or because they love Apple, right? And then there's going to be people like me that are going to buy the iPhone once a bunch of my colleagues and friends have used the iPhone and have a great experience. And the same thing exists within all of our employer communities. Employers, we have all these local network effects, right? Coworkers are going to learn about the vaccine from their other coworkers. And so the question is, what is the role that employers have to enable those connections? And there's a couple really core strategies. One is this idea of helping people see, especially in a virtual world, who's been vaccinated or not. Kind of like the I vote sticker, I voted stickers or other things. How do we create signals or places where people can post that they got vaccinated in sort of social forums and stuff is really powerful. The other one is educating people so that they have a better experience. If people expect no side effects and they get them, they're going to tell their colleagues, don't get the vaccine, it was horrible. If people expect significant side effects and they get less than that, they're going to have a better experience. And so we have an opportunity as employers to educate people, set the right expectations, particularly as the delivery system is overwhelmed and not really being able to do that education at the point of vaccination.
Thank you so much, Dr. Nundy. This next question is directed at Sami. How do you envision that everyday doctors managing diabetes through drugs can realistically reorient and train to take the Virta approach to reversing diabetes? This seems like a monumental, financially conflicted challenge.
Well, thank you for the question. There's multiple layers and a pretty loaded question. So I think there's two challenges, and I think were parts of the question. One is, what if my financial incentive is fee for service? why would I do something that I don't get paid for example, continuous remote care or so forth. So there's that financial incentive, fee for service versus outcomes. I am hopeful, and I know this, most providers truly care about the patient outcomes. So I would not think that any provider is not trying to deliver the best outcomes simply because they make money through transactions. And the other piece is that we talked about value-based care. More and more primary care providers are actually incentivized either partially or completely to deliver better outcomes and save costs. So that would be the one part in terms of economic incentives. And then there's the second part, which frankly is why Virta exists, which is diabetes happens 24/7. And we talked about this continuous remote care. It is very difficult, I would say impossible, to achieve the Virta-like results if you see your patient 2 or 3 times or 4 times a year, when we interface with the patient 2 to 4 times a day virtually. So typically when we work, we partner up with primary care providers and say, you do your work, you do it very well, and we'll help you to address the chronic disease challenges and hopefully achieve, in the case of diabetes, glycemic control that gets us all the way to the disease reversal. So good question. Totally understand the challenges. And I think that's one of the reasons why we had to reinvent the care delivery model at Virta.
So Sarah, if I could jump in there.
Oh, yeah.
If I could jump in as well. I think Sami is absolutely right. And Bob said it before, the patient is the center of this. If the patient takes the responsibility and has the knowledge and then the help through a Virta model or whatever opportunities are available, they will likely work for the best outcome. Primary care physicians and diabetes specialists don't want to be called 3 times a day or 3 times a week with issues on an individual patient. They can't possibly cope with that kind of level of interaction. So the remote continuous care model is actually ideal by empowering the patient and giving them the assistance they need, whether they're on medications or whether they're following the ketogenic diet or whatever approach is being taken to ultimately achieve the best outcome.
Thank you. Thank you so much. We're running close on time, but I did want to sneak in one last question that I think is great because it would apply to everyone here. So last question to all would be about the future of telemedicine specifically. And that is that many states have relaxed regulations regarding telemedicine during the pandemic. Is there any reason to believe that these changes will become permanent given what we've heard today?
The bill is currently before Congress to extend it permanently. So I think that politically the will is there to move it forward. It makes sense. It's the only way to provide universal care.
I agree. I mean, to go back from what we've learned would be just another form of idiocy. I mean, not that we haven't demonstrated that potential before, but let's hope we can move in a positive direction this time.
Yeah, I mean, I agree with both clearly, but I'll add that, I mean, many employers have had telemedicine for a long time, right? And some payers as well. I think that policy is obviously critical, but it's necessary but not sufficient, you know? That I think what we do with the technology, how we drive that engagement, how we personalize that, I think is going to be as important, because those that have had this benefit for 10 years have seen low utilization. I think we still need to also crack that nugget in addition to the universal access.
Yeah, I guess I would echo. So one, certainly we have an entire department responsible for licensing cross state lines, a complete waste of effort. So I would hope that the policy change persists and further improves. And then secondly, Dr. Nundy's comment is exactly right. It's kind of like a pen or computer is one thing, but it's like, what do you use it for? And telemedicine and technology in general, it's just a tool. The question is the outcomes. What are the results? What do you achieve for the benefit of the patient? I think hopefully that is the focus It's wonderful to have the excitement around telemedicine, but again, that alone, it could just be adding costs, maybe a little bit convenient. So I'm very hopeful that more and more companies focused on the patient and the patient outcomes, both clinical and economic, through telemedicine.
All right, well, I want to thank all of our wonderful panelists here today and thank everyone who has joined us. And I think that closing, I'll say, I think there's reason to be both optimistic and excited. And thank you once again to everyone. Have a great day.